to introduce the different speakers. And Mike, it's up to you.
Thank you, Noel. So welcome, everybody. And this session is on the evolution of pediatric endoscopic airway surgery. And as you know, endoscopic surgery used to be airway surgery up really till the late 1960s, early 1970s. And then open airway surgery really became the dominant theme. You weren't considered an airway surgeon unless you could do a big open airway operation. And that was really led by one of my colleagues, Robin Cotton, one of his friends, John Evans. And now you've seen that there's been a resurgence of interest in endoscopic airway surgery. And today we're going to look at the evolution of endoscopic airway surgery. I have Claudia Schweger from Porto Alegre in southern Brazil, who's going to talk to us about endoscopic laryngeal cleft repair, which has had a huge area of interest over the last few years. We'll then transition to Richard Nicholas talking about balloon dilation and the evolution of balloon dilation. Again, a huge area of interest. Shahom Roy from Houston in Texas is going to talk to us about the evolution and the use of lasers with a particular emphasis on safety. And then Carlton Zdansky from the University of North Carolina, Chapel Hill is going to talk to us about the introduction of robotics in endoscopic airway surgery. So we've got a great panel. And with that, we're going to start rolling initially with a pre-recorded talk on endoscopic laryngeal cleft repair from Claudia Schweger.
Hello, everybody. It's a huge pleasure to be here today with you, even if it's just online. Thank you very much for the invitation, and thanks to all my colleagues here that are with me in this session. We are going to talk about endoscopic laryngeal cleft repair. So laryngeal clefts were first diagnosed by Richter in 1792 by palpation of the posterior larynx of a neonate who presented with aspirations. And the first surgical repair was performed many years later in 1955. But still now, in 2021, we still rely only on case series published in the literature and on the expertise of some surgeons, because this is a very rare disease. Babies with clefts may present with aspirations and recurrent pneumonias, choking with feeds, and sometimes cyanosis because of this. Stridor, because there is sometimes associated laryngomalacia because of the prolapse of the soft posterior tissue into the larynx, and sometimes chronic cough in the older baby. Regarding the diagnosis, we all know that the flexible laryngoscopy may lead us to an incorrect diagnosis, since in this flexible laryngoscopy, we usually see only the associated laryngomalacia. The gold standard method for the diagnosis is the rigid laryngoscopy, the MLB. And with the rigid laryngoscopy, we can also classify the type of the cleft, which will guide the management. And talking about diagnosis, so this is a video of an MLB performed but you can see here that we can take a very good look in the posterior commissure. And talking about classification, this is the grading system of Benjamin Inglis of 1989 and the one that we still use nowadays. Considering the high percentage of associated non-syndromic and syndromic anomalies, more than 50%, a systemic evaluation of the child must always be done. We always ask in our hospital for a genetic consultation in these cases. Continuing the evaluation, a VSS or a FIS must be performed, and the classical finding is an aspiration in the posterior portion of the larynx as the liquids enters the larynx through the cleft in the posterior area. But this is not always very easy to see, mainly in very small babies, in which the interpretation of VSS and FIS is sometimes very difficult by definition. So it's not easy to see this posterior aspiration sometimes. And how would we manage these cases? Well, airway compromise should be always managed first. So if the child has severe stridor and retractions, we should consider a CPAP or BiPAP and try to avoid an intubation always, since the tube will be in direct contact with the mucosa of the cleft, and it will cause more inflammation on the area. It will be more difficult to fix the cleft later. And the tracheostomy should be performed in very severe cases only. And if the child is presenting aspirations, an alternative feeding route is necessary, either nasogastric or nasoenteric tube or even a G tube. Conservative treatment also includes liquid thickening and a proton pump inhibitor to avoid reflux on the cleft area and the worsening of the inflammation. Endoscopic injection of some materials in the cleft may be helpful. We're going to see some papers about this, like this one of 2011. And surgical treatment, on the other hand, may be open or endoscopic, depending on the grade of the cleft and also on the difficulty on laryngeal exposure to fix the cleft. Endoscopic surgeries are mainly reserved for types 1, 2, 3A, the type in which the opening occurs in the entire cricoid, but do not extend beyond the cricoid. And here's just an example of the endoscopic surgery. We are just tying the last stitch up in the cleft. And here there are some tips about the endoscopic surgery of the cleft. So make sure that mucosa is totally denuded. Mucosal division can be made with CO2 laser or steel, it doesn't matter. Suture high, the most proximal sutures through cartilage should be through the cartilage. Use PDS. Use simple interrupted sutures through laryngeal and esophageal mucosa. And as I said, tracheostomy maybe not necessary, and the exception is type 3, when there is airway compromise. We always release the airway epiglottic folds in order to not worsen the obstruction of the child by closing the cleft too narrow, too tight. we always resume preoperative diet. So if the child used, for example, used to receive only thickened liquids before the surgery, resume this kind of diet before you repeat the VSS and MLB in 6 to 8 weeks. This is safer than just starting a new diet soon after the repair. So sometimes the child can aspirate soon after the surgery. And here's the post-operative MLB of the previous child, the one with a lot of mucosa in the cleft. So you can see it is closed and the child improved a lot. These figures here were kindly provided by Dr. Mike Rudder, our moderator today. I'm not sure if he drew the figures by himself or not, but they are very pretty. And they are here to give you a very important tip in fixing the cleft, because we should always avoid suturing with inverted suture edges. Or we are going to have a dehiscence of the suture, since less denuded mucosa is in contact and suture together, compared with this kind of suture here. And talking about just closing the defect, this very nice paper showed that sometimes just fixing the cleft is not enough. They included 60 children from 2002 to 2012 with an average of 10 months after the surgery. And we can see that more than half of the children still presented some degree of penetration and aspiration almost 1 year after the surgery. And they conclude that dysphagia, even in this what seems to be a very anatomical cause of aspiration, is actually multifactorial. Other causes include other anatomical issues, comorbidities, and also depends on the neurological status of the child. In this very recent meta-analysis and systematic review, they included 24 studies comprising more than 700 patients. And this is the biggest study meta-analysis we have so far. So 38% of the patients received injections as the primary treatment, and aspirations decreased from 91% to 62%. And 54% of the patients received endoscopic surgical repair as the primary treatment, and aspirations decreased from 73% to 28% in VSS or FIS after the surgery. And they conclude that both treatments are safe and effective in treating clefts, because even for the injection, even for the injections, 90% of the parents reported symptom improvement sometime after the surgery. So they conclude they are both successful. And here just show you when we extend our indications of endoscopic surgery to type 3B as well. You can see that the success rate is lower, around 60%, and only half could take out the NG tube. And to finish, what are the main difficulties we have in managing clefts? So first of all, and this is an amazing point to discuss here, is it really a type 1 cleft? Is just a deep notch, or it's a normal posterior larynx? This is really very difficult to determine sometimes, even if we have experience on the issue. So laryngeal cleft repair is sometimes diagnostic for some authors. For example, if the dysphagia improved after the endoscopic surgery, even if it were just a deep notch, it is considered a physiological cleft, even if it's not an anatomical cleft. Then if you are not sure, sometimes suggest a couple of stitches in the posterior larynx, and it seems to help some children. But this must be discussed with parents, and the pros and cons must be addressed, because it's not something that we are sure that will improve the child when we are in doubt if it's normal of a deep notch or a type 1 cleft. And I think this is my last slide. Thank you very much.
Thank you very much, Claudia. And with that, we're going to hold questions till the end, and we're now going to proceed with Richard Nicolas from Marseille, talking about the evolution of endoscopic balloon dilation.
Thank you, Mike. Can you see my screen?
Yes, we can.
Okay, thank you. Well, hello, everybody. And first, thank you to you, Mike, and to Noel for inviting me in this great roundtable to talk to you about balloon dilation. As you can see here on the right. So what are the principles? The principle of dilation is to enlarge an airway using pressure applied perpendicular to the lesion. And here we are with a surfacic dilation. First, people used angioplasty balloons. Then others, like we do in our institution, use esophageal dilation balloons. And then here we have on the right, on the scheme, most of the technology in the balloons nowadays. Thank you, Mike. I read with a great interest your patent, and it's really a wonderful tool. So now, using principles, we have first to select the good case. By the good case, I mean the good patient with the good pathology amenable for endoscopic procedure. Now we selected the patient and pathology, we have to select the good case for balloon dilation. And then, well, then let's dilate. And what else? We have first to appreciate immediate results during the procedure. Do you think that your procedure is or not efficient? Second is middle-term result. Do you have any recurrence? Do you have often recurrence? If yes, maybe you want to move to a different option. So first step, the immediate result. First case on the upper right is the case of an acquired tracheal stenosis. We use first laser and second dilation. And as you can appreciate, we are not doing plastic surgery of airway. We're just providing a good airway, nothing else. But it's quite really important, and I think it's enough. The other case, we'll see the video later. It's an acquired subglottic stenosis after multiple intubation, and you can appreciate an immediate result, which can be considered as good. But after how many procedures may we change? After how many procedures may we have to think about operating externally? In our experience, I think that 3 times is a good value. More than 3 times, I think you have to think about changing your approach. So in our experience, I looked over the last 10 years. We operated on 147 patients with an endoscopic airway procedure, out of which 37 only had balloon dilations with 107 procedures. So a mean of 2.9 procedures per patient and a median of 2. And you can see that in only about 11% of cases, we have to move to an external approach. A technical particularity in our team, we just found upon diameter and not pressure, because when you see in the literature, very often authors say, well, we dilate at 3 atmospheres, 4 atmospheres anyway. Without devices, I prefer to found upon diameter. So balloon is an endoscopic procedure, and endoscopic procedures can be used either as initial treatment or secondary treatments. In our series, it was essentially as initial treatment, and you have 2 cases. First, acute lesions, and the concept is to crush your lesions to enlarge the airway. This example is the case of a child who had a lot of failure of extubation. So the intensivist referred us this kid, and we performed just 1 dilation. And after that, it could be extubated. So introduce the balloon. Sometimes people tell me, how long do you let the balloon in your larynx? I say all depend on the level of oxygen in the blood. When you have less than 90%, you have to open the airway and to deflate your balloon. That's in our experience. Second case, if you had fibrous lesions. In this case, crushing will not be efficient. You have to cut and then enlarge. First example, the one of a subglottic acquired stenosis. In this case, we use Noel Garabedian's laser, so thulium laser. And we perform, as usual, stellar incisions. And then we use a balloon. And you'll see that after dilation, the result is quite good. And in this case, it could be plastic surgery also. In the other case, you remember the previous slide. It's an acquired subglottic stenosis. For this child, we'll use David Albert's laser. It's not exactly the same, but it works also very well. Dilation, and you'll have the immediate result on the left. And this kid had to be operated on for something else, I don't remember what exactly, 4 years later. And so we performed an endoscopy before intubation, and we saw a very good result with just a very thin scar on the subglottis. Now balloon can also be used as secondary treatment. And this was the case of a baby who underwent an LTR, a single stage LTR, and after some days, he had respiratory distress, and we found these granulomas and edema. So in this case, we think that Noel-Garabedian's laser is better. And after we dilated, with a good immediate result. And on the right, we have a control at 10 months later. You see the anterior cartilage very well included in a good subglottis airway. So if you want to sum up, you can say airway surgery. It's quite safe, it's quite reliable, about 90% of success, and is usable whatever the age, because you can have a different size of balloons. But in 10% of the cases, you must be able to perform an external surgery, because as Mike told in his introduction, endoscopic airway surgery remains airway surgery. So if you perform balloon dilation, you have to be sure that you or somebody of your team is able to perform an external procedure if necessary. I thank you all very much.
Thank you very much, Richard. It's a wonderful talk, and again, we're going to try and hold questions till the end, and we're also answering some questions that are being typed. We're now going to move on to Roy's talk on surgery.
Of laser airway surgery for the pediatric airway was from Dr. Healy's group. And he made an interesting statement that said that introduction of the carbon dioxide laser is the single greatest advance in transoral surgery of the airway over the past 15 years. And the laser started to really take off in terms of its utility in pediatric airway surgery. At that time, it was felt that there was really nothing that we couldn't treat with a CO2 laser. Supraglottic, glottic, subglottic, tracheal, oropharyngeal, hypopharyngeal, wherever your lesion was, we could treat it with a laser. If you had an airway problem and we had a laser, we didn't have a problem anymore. We now had a solution. And that worked really well for a while until we started to realize that lasers have complications associated with them. And the first recording of this I could find actually came from Seattle Children's Hospital, from Dr. Perkins and his group, where they identified 7 cases of iatrogenic airway stenosis from patients who had been recurrently lasered for recurrent respiratory papillomatosis, sometimes having laser surgery every month, resulting in stenosis. And so it was the first description that really lasers actually have complications. And over the years, I think we've started to adjust our thinking about how lasers can be utilized in the pediatric airway. As with any new technology, it goes through what we call the Gartner hype cycle. And that's where a technology is immediately adopted with inflated expectations. And I think that's what happened from the 80s to the 90s. And then later in the 90s, when we started to see more complications, we started to realize that maybe it wasn't as good as we used to think it was, until eventually we hit the trough of disillusionment, where people said, let's stay away from this for a while. And then by the time I finished fellowship, I think we started to realize that there were times where lasers could have good utility in the airway, but eventually now we've sort of hit that plateau where we've realized what it's most useful for and times where we should avoid it. And this, to me, in many ways mimics other things that we do in pediatric otolaryngology. In the time that I've been out of training, I've noticed that we've had this sort of pendulum swing in pediatric otolaryngology. As an example, endoscopic sinus surgery. When I was in medical school, that was all the rage for children with sinusitis. Everybody was doing endoscopic sinus surgery. And then we got away from it for routine chronic sinusitis and realized it could be better treated medically. And I think that this pendulum goes back and forth. We've seen the same thing happen between open and endoscopic airway surgery, where at one time it was really everybody got open surgery, and then we realized, hey, a lot of people can be treated with endoscopic surgery, and eventually we're finding the balance. Like all things in a pendulum, sometimes you're the prison warden, and other times you are the prisoner. Yes, Mike, I used that slide. So, certainly we know that we have different lasers in utility in the pediatric airway. The one most commonly utilized is, of course, the CO2 laser, and that is absorbed by tissue water. And the CO2 laser is great because it gives you very precise dissection and you have remote manipulation. But the CO2 laser also can cause significant surrounding thermal injury, which leads to scarring and edema. Now, using the ultrapulse mode can reduce that thermal diffusion and reduce the risk of further injury, but we know now that the CO2 should be used cautiously because of the risk of forming scar tissue around it. The KTP, as an alternative, gets preferential absorption into hemoglobin chromophore. And so it's great for vascular lesions, and it's delivered fiber optically, but it still can cause damage to surrounding tissues, and it can still set you on fire if it's not utilized correctly. People have dabbled with other lasers in the airway, the Nd:YAG and the argon laser, but there's some unpredictable spread of thermal injury with these things and an increased risk of transmural injury. And so most people have gotten away from using Nd:YAG and using argon lasers for airway surgery in children. Now, I still think that the laser does have utility in pediatric airway surgery. So, for example, I use it for laryngeal cleft surgery. And I was going to show you a video of that, except I realized that Dr. Schweiger is probably going to do an excellent job with that. I use it for transoral base of tongue resections, for thyroglossal duct cysts, and sometimes for posterior cricoid splits. So if I need a rough edge or a raw surface, or a very precise dissection, and I don't mind any surrounding scar tissue, like in the base of tongue or in the laryngeal cleft, I like using the laser. It's hemostatic, and I think it's great for that precise dissection. But I don't like using it in places where scar tissue could be a real problem. So, for example, I no longer use it for supraglottoplasty because of the risk of supraglottic stenosis. I don't really use it in the subglottis anymore either. I certainly don't use it for RRP, and my guess is most of the people watching this talk don't use it for RRP anymore. And a big reason for that is we have better treatments now than just the laser. We have better medications, for example, propranolol for hemangiomas. We have better instrumentation with balloons and microdebriders for stenosis and for RRP. So we have better technology, which allows us to avoid the laser in some circumstances. But I still think it has utility in certain circumstances as long as we're attuned to the risk of surrounding thermal damage. And there's not been a lot of literature about the risks associated with using laser, but I did find a nice paper from Boston Children's Hospital where they talked about CO2 laser supraglottoplasty, which actually is associated with an increased risk of a prolonged ICU stay compared to the cold steel technique. And so we do know that there are risks that play out in these patients who receive laser treatment in their airway. And if you're going to use a laser, please be prudent about doing so. The Pediatric Society of Anesthesia actually surveyed pediatric anesthesiologists and found that 20% of the time, anesthesiologists were using an FiO2 greater than 90% during their laser activation, and almost a full third of them were not waiting for the O2 to wash out before activating the laser. Even more frightening, almost 40% of pediatric anesthesiologists weren't using a laser-safe tube because they didn't have one in an appropriate pediatric size. And 2% of them had an airway fire as a result. And we know that airway fires are a real risk with laser ignition. And in fact, lasers are the single most common ignition source in airway fires. We know that fires are caused by a triad of oxidizers, fuels, and an ignition source. Lasers are the #1 ignition source that are cited for airway fires. And this is what that looks like. This is what my research team is very interested in, is in laser fires. And so if you misfire a laser at an endotracheal tube, you can get a fire activated rather quickly in these situations. And you'll see that the damage can be quite extensive. This is obviously a mannequin model, not in vivo model, but you can actually see the methylene blue on the posterior subglottis along the cricoid there, where the methylene blue in the cuff exploded. So it causes significant thermal damage. And this video is just to show you what that looks like as a modeled experiment. You're going to see the fire from firing a laser at a reinforced tube that unfortunately exploded the cuff, and a fire occurs, which can be really quite devastating for patients. So I'll skip forward so that you can see the damage that occurs because the fire spreads down distally into the lung fields. So we know that if you do use a laser, please use it carefully because it does have significant risks involved. One quick pitch I have to make is that there's a new laser-safe endotracheal tube on the market called Tenax. It's a double-cuffed reinforced tube, which is going to be much safer than previous iterations of laser-safe endotracheal tubes. Full disclosure, I was the inventor of this tube. But it's out on the market now, and I think if you're interested in laser-safe tubes, you should take a look at it. So if you're going to do laser surgery, just keep in mind that a lot of the cases you used to use the laser for can now be done more effectively without a laser. We have microdebriders, balloons, coblators, things that we can use that aren't as risky as the laser. And if you're going to use a laser, don't use an endotracheal tube if you can avoid it. If you do use an endotracheal tube, use a laser-safe endotracheal tube with a balloon filled with saline. But even removing the tube alone is not a guarantee that prevents fire because tissues can light on fire because they have fat, so they're flammable. So keep your FiO2 to a bare minimum necessary when you do these cases. So to summarize, I believe that lasers still do play a role in pediatric airway surgery, but not at the level that we used to use it before I got out of training. And I think that that's a good thing because I think we become more refined in our decision making because lasers do have significant benefits, but they also have significant risks. And we should use them judiciously, which is a word we don't use in pediatric otolaryngology often enough. So I put the definition down in the bottom corner there. As my friend Dave White in South Carolina likes to say, when it comes to techniques, don't fall in love with any one particular technique. And if you do use a laser, use a battery of precautions for safety's sake. So I'll leave you with that. Enjoy the conference. Thank you all for having me. It's been a privilege.
Thank you very much, Shahom. And again, for those of you who don't already know, Shahom is probably the laser safety expert in the United States at the moment. And so I greatly appreciate that very erudite presentation. We're now going to transition to Carlton Zdansky. And Z is the American pediatric expert in airway robotics, and he's at the University of North Carolina, Chapel Hill. And Carlton, would you be so kind? Thank you.
Hi, I'm Carlton Zdansky, and I'll be speaking about endoscopic robotics. First of all, thank you for the kind invitation to speak today. I have no relevant financial disclosures. So tours in the pediatric population, robot-assisted surgery is well established in abdominal surgery, urologic surgery, and even head and neck surgery. But in pediatric otolaryngology, it almost exclusively applies to transoral robotic surgery or TORS. When I think of pediatric tours, this is the image that comes to my mind: the robot, child, safe airway. And this is the image that frequently comes to the mind of our anesthesiologists, which robots attacking our children. But it's not even a robot. A robot is something you pre-program to do a task and push a button and it does it. This is nothing like that. This is a surgical platform. It will only do what you ask it to do, with the inevitable quirks that come along with some machines. So to put that in context, here I am. I'm in Malawi. This person had a mastoiditis and a brain abscess, and here I am doing a mastoidectomy with a headlight and a hammer and a chisel and a rongeur, which you can do. You can do quite well. I think you can do it better with a microscope and with a drill. And I was very excited the following year when we did in fact have an orthopedic hand drill that I could put a burr on and do again another mastoidectomy on an acutely ill patient, but this time with some powered instrumentation. So I think we would all agree that you can do otology, you can do a mastoidectomy without a microscope and a drill, but it's a lot easier and a lot better. We can do rhinology without the endoscope and the powered instrumentation, and we can do skull-based surgery without navigation, but these tools make it so much easier and so much better. And we can do pediatric airway work without laser technology or balloons or debriders or advances in anesthesia, but all of these things make it much safer and easier. And I would argue that for some pathologies, the robot does the same thing. So we're doing the same job, we're just using a different tool. So we really have to thank Dr. Evar for opening up this field of pediatric tours back in 2007. And I used to joke about there being an explosion in the literature between just a few people in the field, but that really in the last few years, 3 or 4 years, has gotten quite bigger, quite more robust with respect to the literature. Our series came out in 2016 with 16 patients with a variety of pathologies, including tongue hamartoma, lymphatic malformations, a lot of laryngeal clefts, some pharyngeal strictures, and 2 congenital laryngeal cysts, one 27-day-old 2.5 kilogram child with a saccular cyst. So when you look at all of these patients, 2 things kind of stand out, or I want to point out. One, you can get into the robot into very small patients, 2.5 kilograms, ASA4. Not an easy case, but the robot was used successfully. I wouldn't necessarily start here. This might be a better choice if you're starting robotics. They're 93 kilogram ASA2 with an easily accessible base of tongue lymphatic malformation. So when you're starting your program, I would suggest that you start big. Go after well-known, easily accessible pathology that you can convert easily to traditional methods, rather than starting with the 2.5 kilogram child. So here is one of our first cases, which will illustrate a few things illustrated here. 1, laser safe tube. 2, the robot docks by sliding underneath the bed, which is turned 90 degrees. We typically will have the anesthesia circuit coming off to the side. There is frequently gum protection. There are 2 surgeons involved. 1, the robotic surgeon who operates the robot. The second surgeon, equally important, is at the bedside and protects the patient from the robot, protects the airway, and assists and often directs the robotic surgeon. The robotic arms enter from the sides along with the camera. So that's 3 arms in the mouth. And then the bedside surgeon can also place 2 instruments in. And so you have 4 hands, so to speak, in the airway. Here you see an adapter with a D-ring that the robot can grab, and this will house a laser fiber of your choosing, which can then deliver laser energy to whatever pathology you're operating on. In this case, it is a cyst. Here, just in the interest of time, we'll go to the complete removal of the cyst. You can see that the cyst is being retracted after being decompressed, and the laser is being used now to perform the coup d'etat, and the cyst is thus delivered. You can see this patient has no retractor in place. The tongue base is just being held out of the way with the robot. Here's a preoperative picture. Here's a postoperative picture after the saccular cyst has been removed, and I think you'll agree that that's a hard resection to duplicate in a 2.5 kilogram child. with straight instruments. One point here, one limitation, you'll notice that this child has some excoriations in the subglottis due to the fact that laser-safe tubes in this size are hard to come by for some patients. So really small patients, you might have to modify your surgical plan. So again, here's preoperative saccular cyst, postoperative saccular cyst, and the endotracheal tube. Additional cases involve robotic surgery for a 6-year-old with a lymphatic malformation. Now, this child had a giant cervicofacial lymphatic malformation that had undergone multiple excisions externally, but still had a tongue-based component along with retropulsion of the epiglottis. The robot's prepped. In this case, we use a tonsil gag and we suspend it from a mustard table. This child obviously has a tracheostomy. And again, the robot is docked, camera, 2 arms, bedside surgeon. You can see the bedside surgeon here is in pre-COVID days. And again, we'll have 2 instruments. Here we're using a Bovie instead of the laser. The Bovie is very good on tongue base. And you can see here that it's quite effective. One thing you don't see is the suction, which can do several things. 1, suctions blood. 2, suction smoke. 3, it keeps the telescope from fogging up. The scope gives you binocular vision, which you don't have with standard endoscopes. There is no haptic feedback, but you get a pseudo haptic feedback just from using the laser, using the robot enough. And here you see that the tongue-based lesion has been excised. Here is one unique feature of the robot is the teaching surgeon can draw on the console and show the student surgeon where to throw stitches, or if they don't like that, they can put other feedback on the screen for the learning surgeon. And here you can see this device is very well adapted for the glossoepiglottopexy, and you can see the epiglottis being sutured up to the tongue base effectively. And here's what that looks like after a partial pharyngectomy, invasive tongue resection, glossoepiglottopexy. You see a much improved airway, and then this child 6 months later with a nice durable repair and some subglottic stenosis that probably has to be addressed, probably not with a laser, with the robot. One of the pathologies that's particularly amenable to repair with the robot is the posterior laryngeal cleft or laryngotracheoesophageal cleft. Here you saw a cleft that went through the cricoid into the trachea minimally, so not that large a cleft, but deeper than a type 1 perhaps. Here you're using the laser, again with the D-ring and the delivery device to freshen the edges of the cleft. And here you see this occurring on the right side. There's a laser safe tube, which is behind a tonsil gag. This patient is about 8 kilograms, 8 months old. Here you can see that we're actually placing intraluminal stitches on the, the laryngeal surface of the airway. And you can see that the robot can get down there pretty effectively, and you can throw stitches very precisely. So here we're closing the mucosal layer on the larynx and trachea side. After that's closed, we typically will throw a mask closure submucosal stitch, and then we'll close up the posterior larynx as well. And here you can see those stitches being thrown and tied. Here you see the camera is fogged, and so just placing your suction in there will help to keep that from being unfogged. Again, the teaching surgeon can draw where they want the learning surgeon to throw their stitches. It is also possible with the newer robots for the the teaching surgeon to take over the robot and actually run the robot remotely from out in the hall, or technically from halfway across the world if need be. So here you see completion of the cleft repair. You can see we're throwing one more stitch. I think that it's kind of difficult to get this many stitches this precisely in small children, at least for me, for a laryngeal cleft repair. And I've found this tool with its magnification and its binocular vision and its wristed instrumentation to be very effective. And here's the complete repair. We're going to you can see that there is much more magnification than we're actually using. You can zoom in quite closely. It's frequently hard to work when you're quite so close or quite so magnified. And so that is the complete repair. And we will be now removing the tube and examining the repair from the intraluminal side. We tried some posterior laryngeal stenosis, posterior grafts. And so here you can see that the robot is actually being used to retract the larynx. There is a laryngeal spreader here. There is actually a laser which is being used to open the posterior glottis. And so you can get some stitches in there as well. And you can actually get a graft in place with this method. The main problem is it doesn't really add much to the posterior laryngeal stenosis than straight sticks. And so I've gotten away from doing that. I did a couple and I didn't think it added much benefit. So what does the future hold? It holds basically flexible instruments. And here you see the MedRobot. This slide is courtesy of Dr. Roy, who spoke earlier or later. I'm not sure. I'm recording this. And so here you can see the MedRobot can actually get down into the trachea. We're going to have our own retractors made just for ENT and our own instruments also for ENT. And so that should dramatically improve our ability to operate in the airway. I think you can take this robotic surgery thing a little too far. Perhaps robotic hair transplantation is not something I'm going to explore, but I think that we're starting to address some of the challenges, and I think we're ready to really see use of the robot increase. So when you think about the surgical robot, don't think about a robot as this one or this guy or this guy. Think of the robot more like this. It's just a tool, nothing else. And the other concluding points I'd like to make that TORS in the pediatric population is feasible and safe. Their indications are expanding. We need to do some deeper dives on case matching and time in the OR and outcomes. And if you're contemplating TORS, use a two-surgeon approach and start big. Go with a big patient that you can easily get to the pathology and can easily convert to your traditional methods if you need to. Thank you again for the kind invitation to talk.
Thank you very much, Carlton. So, and again, I'd like to thank all of our panelists for their presentations. And really, a lot of this is the sort of the cutting edge of what is being done endoscopically at the moment. There's an apology from Claudia Schwager. She's on call and there's been an emergency at the hospital in Porto Alegre. So she's left